Okay. So the main questions I'll be discussing here are on assessment of a nutritional status in a critically ill patient, how to make a nutritional plan in a critically ill patient for enteral nutrition, refeeding syndrome, gut dysbiosis and probiotics, and trials in nutrition. So coming to the first question, assessment of nutritional status in a critically ill patient. So why assess nutrition in ICU? Because critical illness is associated with hypermetabolism, catabolism, and rapid muscle loss. So why this is a problem is lean body mass that occurs because of this rapid muscle loss has been attributed to increase in mortality, increase duration of ventilator, and length of hospital stay. So this is why nutrition has been taken as a very important factor in ICU management. So malnutrition is associated with increased infections, poor wound healing, prolonged ventilation, and increased mortality. So guidelines recommend systematic assessment on ICU admission and monitoring during stay. So coming to the screening tools, the one which most of you would know about is about the Nutrix score. So it has 6 parameters. So age, the Apache score, SOFA score, the comorbidities, the days from hospital stay till ICU admission, and IL-6 if it is available. So the total score can be calculated from 0 to 5, where it would indicate a low score, and from 6 to 10, which would indicate the high score. Now, how do you interpret a low score and a high score? In a low score, if it is low, it indicates a low malnutrition risk. It is less likely to benefit from aggressive nutrition therapy. Whereas if it is a high score, then it is associated with worse outcomes like mortality or prolonged ventilation. So these are the subsets who would benefit from aggressive nutrition therapy. So aggressive nutrition therapy is the main word that you need to keep in mind when you mention about Nutrix score. Then you have something called the modified Nutrix score. So here IL-6 is omitted because in many centers they would not be doing serum interleukin 6 levels. So in that kind of a scenario, it can be omitted, where the other parameters alone can be looked into: age, Apache 2 score, SOFA score, number of comorbidities, the day from hospital to ICU admission. So the interpretation, you just reduce 1 point from the original score, 0 to 4 and 5 to 9. So based on that, you can classify it as low risk or high risk. Then you have something called the MUST tool, that is the malnutrition universal screening tool. So here we have 3 factors that you need to keep in mind. One is the BMI, the next one is the unplanned weight loss in the past 3 to 6 months, and acute disease effect. If the patient is acutely ill and has had no intake in the last 5 days. So BMI of cutoff is between 18.5 to 20. Weight loss, the cutoffs are between 5 to 10. And the disease effect, the score, if there are if the disease effect, if the nutrition intake is for more than 2 days, then that comes into the criteria and a score of 2 is given. So the total score is 0, 1, and 2 or more. So based on that, you can classify it as low risk, medium, and high risk. If it is low risk, you go with routine clinical care. Medium risk, you observe, monitor, and consider dietary support. If it is high risk, then refer to a dietitian and implement nutrition support plan, either oral, enteral, or parenteral as appropriate. So for must, you need to keep 3 things in mind. One is the BMI, unplanned weight loss, and an acute disease effect with decreased nutritional intake for a period more than 5 days. Then you have the NRS. So this one is favored by the SPEN guidelines. So that is the nutrition risk score that came out in 2002. So it combines nutritional status with the disease severity. So in nutrition status, you have 4 parts. That is normal nutrition, mild impairment, where there is more than 5% weight loss in 3 months, or food intake of 50 to 75% of normal in the last week. Moderate, more than 5% weight loss in 2 months. Here it was 3, here 2, or BMI between 18.5 to 20.5, or intake of 25 to 60% normal. And severe is more than 5% weight loss in 1 month, or BMI less than 18.5, or intake of 0 to 25% of normal. All right, so you have a score of 0, 1, 2, and 3. And for disease severity, you have normal, mild, moderate, and severe. Normal is no increase needs. Mild is like hip fracture or chronic disease with complications. Moderate is major abdominal surgery, stroke, or severe pneumonia. Severe is head injury, ICU patients with an Apache 2 score more than 10, sepsis, or bone marrow transplant. Then you have an age adjustment. So you need to add 1 point if the age is 70 years or more. And based on these three, you need to calculate the score. So if the score is 3 or more, then there is a nutritional risk and nutritional support is indicated. So this is how we proceed about the NRS scoring. So nutritional status assessment, disease severity, and age assessment. Then we have the subjective global assessment. If you see the actual assessment sheet, it is supposed to be for 2 pages. So I have condensed it from an exam perspective. So there are two areas that you need to look into. One is the history and the other one is the physical exam. So under history, you need to look into the weight change, the dietary intake, GA symptoms, functional status, and the metabolic stress. So weight change, more than 10% loss in 6 months or more than 5% in 1 month. Dietary intake, reduced intake compared to usual, anorexia or poor diet. GA symptoms, persistent nausea, vomiting, diarrhea, or anorexia more than 2 weeks. Functional status, decline in activity, fatigue, or bedbound. Metabolic stress like fever, sepsis, trauma, or major surgeries. Under physical examination, you need to assess for subcutaneous fat, that is seen as loss of fat in the triceps or chest, where the ribs are very much visible, or presence of muscle wasting, temporal hollowing, or at the clavicle level, or prominence of shoulder and quadriceps wasting. Presence of edema or ascites may mask weight loss, considered as malnutrition indicator if unexplained. So you, based on this, you can calculate the rating as A, B, and C, where A is well nourished and C is severely malnourished. So the important thing you need to keep in mind is for SGA, it takes history and examination into consideration. So it is subjective but validated, simple, and widely used at the bedside. Why this SGA is important is in the ISCCM nutrition guidelines, SGA is the one which they recommend. So then you need to assess the risk factors for malnutrition in ICU while you assess the patient. If there was pre-existing malnutrition like chronic illnesses, cancer, CKD, cirrhosis, prolonged NP or inadequate intake pre-ICU, hypercatabolic states like sepsis, trauma, burns, ARDS, or pancreatitis, and prolonged mechanical ventilation. So these are the common risk factors for malnutrition. Then you assess the clinical and anthropometric assessment, the weight and BMI, the role of which are limited in fluid overloaded patients, recent weight loss or reduced oral intake, muscle wasting, loss of subcutaneous fat, may be masked by edema, hand grip strength if it is feasible, and functional assessment. So difficult weaning from ventilator may suggest muscle loss. Then lab and biochemical markers, they are by themselves not reliable because inflammation alters albumin, prealbumin, and transferrin levels. So they can be used to monitor trends and complications. Like example, sodium, potassium, magnesium, and phosphorus can be used to assess the risk of refeeding syndrome. And micronutrients like zinc, selenium, vitamin D, B12, and folate levels can be assessed in patients who are in ICU for a prolonged period of time. Then metabolic assessment can be done by indirect calorimetry, which is considered as the gold standard for energy expenditure. If IC is not available, then you go with predictive equations, that is 20 to 25 kilocalories per kg per day initially and then adjusted. You need to importantly note one thing. In obese patients, burns, those on CRRT and sepsis, this metabolic assessment needs to be modified accordingly. Then ultrasound for nutrition assessment. In recent advances paper, this is a very, very high potential question. So I would recommend to give a thought into this. So the main rationale for this is can be done at the bedside. It is non-invasive and repeatable. It is not affected by fluid overload like BMI or weight. It detects muscle wasting early and monitors effectiveness of nutrition therapy over time. All right. So the parameters that you can assess with ultrasound are muscle thickness. So the site where you do it is at the quadriceps femoris, that is the rectus femoris and the vastus intermedius. The other size that can be done at the biceps, triceps, and abdominal wall. So the key findings that can be there is decrease in thickness up to 10% loss can be there in the first week following critical illness. So the significance is it correlates with muscle mass, strength, and outcomes. Then coming to cross-sectional area, you can assess it using the rectus femoris. It is supposed to be more accurate than the thickness alone, and it is a better measure of global muscle mass. Then coming to echogenicity, you can use it for any muscle. Increased echogenicity indicates increased fatty infiltration or fibrosis. It reflects muscle quality, not only quantity. Then you can assess the diaphragm thickness and excursion, which most of you would know about. So the site is the diaphragm. So if there is a decrease in thickness or excursion or thickness fraction, then it predicts prolonged ventilation and weaning failure. So these are the 4 things that you can assess using ultrasound in relation to nutrition assessment. So next question is how to make a nutritional plan in a critically ill patient for enteral nutrition. So first is look for contraindications. So if there is hemodynamically instability or shock, bowel obstruction, severe or protracted ileus, major or upper GA bleed, intractable vomiting, gastrointestinal fistula, gastrointestinal fistula, and abdominal compartment syndrome. So these are all considered as contraindications for enteral nutrition. So the initial assessment is first you need to go ahead with the nutritional risk screening. So you go with validated tools like Nutri-Score. Like I said, you need to assess the Nutri-Score to assess whether you can go with the aggressive nutritional therapy in high risk groups. Then you can assess the M-Nutrix score, which is another alternative. Then you can assess the subjective global assessment tool. Then anthropometrics and clinical parameters like BMI, then weight, muscle mass, edema, or presence of organ dysfunction. Then lab parameters that can be used are prealbumin, then electrolytes, glucose, renal, and liver parameters. Then disease severity like sepsis, ARDS, and shock states. So these can be kept in mind. Then the timing of enteral nutrition. They say it needs to be started as early as possible. So start within 24 to 48 hours of ICU admission if the patient is hemodynamically stable. If they are on vasopressor supports, delay until MAP is stable and lactate is improving to avoid gut ischemia. Then caloric requirements in the early phase, that is the first 4 to 7 days, start with a hypocaloric feeding, that is less than 70% of the needs to avoid the risk of overfeeding. So then target energy after stabilization would be 25 to 30 kilocalories per kg per day as per the ESPN and ASPEN guidelines. And for assessment of energy expenditure, you can go with indirect calorimetry if available, or you can go with predictive equations like the one I had mentioned previously. Then protein requirements, you go with 1.2 to 2 gram per kg per day, higher in burns, trauma, sepsis, lower in advanced liver or renal dysfunction without renal replacement therapy. During CRRT and hemodialysis, you need to increase the protein intake to 2.2 to 2.5 grams per kg per day. Then regarding the route and formula selection, nasogastric is preferred or post-pyloric should be considered if aspiration risk is there or intolerance. So the formulas that can be used are standard polymeric formulas for most patients, semi-elemental if malabsorption is present, and disease-specific feeds like renal diet, hepatic diet, or diabetic diet when indicated. So high protein formulas are often preferred in ICU. The main reason, like I said, is because of critical illness causing a decrease in your lean body mass. It is always preferable to go with high protein formulas. So then the feeding strategy. We start at 20 to 30 ml per hour. Advance it gradually over every 4 to 6 hours as tolerated. So this is not a standard norm. This varies with each ICU protocol. All right. So what I mentioned here is based on the ISCCM guidelines. So continuous feeding is preferred over bolus in critically ill patients. Continuous feeding with pumps or gravity bags can be preferred with use of fine bore tubes, that is 8 to 12 French. Then scientific feed formula should be preferred over blenderized feeds to minimize feed contamination. Check gastric residual volumes by syringe aspiration and not by suction pump. This point is very, very important. And GRV of less than 300 ml can be refilled if it is not blood stained. Whereas if it is more than 300, it is recommended to use prokinetics. And other indications for use of prokinetics are regurgitation or aspiration of feed contents. Now, with regard to use of the prokinetics, SPEN guidelines recommends only two. One is metoclopramide in a dose of 10 milligrams 12th hourly to 8th hourly. And the other one is erythromycin in a dose of 250 milligrams 8th hourly. So, main concern with erythromycin is you need to give it for a maximum of 48 to 72 hours because after that period, the risk of tachyphylaxis sets in. So, most of the setups, metoclopramide is what is used, routinely used. Other drugs like cisapride or levosulfuride also can be used, but they are not recommended as per the guidelines. The next is monitoring and adjustments. It is always important to monitor the electrolytes, especially potassium, magnesium, and phosphorus, to assess for refeeding risk. And along with that, you need to assess the glucose levels and the hydration status. Assess for GI tolerance, that is, you assess for distension, vomiting, diarrhea, or constipation. Assess for aspiration risk. Always keep the patient in a head-up position of 30 to 45 degrees. And if refeeding syndrome is present, you start slow, then supplement thiamine also and correct electrolytes prior to feed initiation. Micronutrient and adjuncts provide daily vitamins and trace elements, especially if the patient is in a prolonged ICU stay, because they will be having deficiency of trace elements and vitamins. So vitamin D, selenium, zinc supplementation, if deficient, should be given. The other trace element I missed is chromium. So that also needs to be given. Special considerations in obese patients, that is BMI more than 30, you go with the hypocaloric, high protein feeding. That is 11 to 14 kilocalories per kg of the actual body weight and the protein of 2 to 2.5 grams per kg ideal body weight. And in AK and CA30, you can go with higher proteins. In severe liver failure, adjust proteins carefully, but avoid unnecessary restrictions. Because many a times, because of hyperammonemia causing hepatic encephalopathy, there is always thought process that you need to cut down on the proteins or limit the proteins. That concept is now not there. And in shock, you delay feeds till the perfusion is restored. Simple to say once you receive the patient, you stabilize the patient is on dual vasopressors, but that vasopressor concentration is static or it is starting to reduce. That is the point when you can start feeds because that is what is called as a stable shock. So this is just what I adapted from the ISCCM guidelines. So on patient admission, check if they are stable or not. If they are not stable, wait for the stabilization. Then if they are stable, then you assess the patient for risk of malnutrition. So you do the Nutrix score and the SGA, do anthropometric assessment if it is feasible, assess the electrolytes and the nutritional requirements. So you can use indirect calorimetry or algorithmic formulas. If enteral feeding can be initiated, you go ahead with that. You assess if oral feeding can be given. If not, then you go with enteral feeding. So enteral, the ideal one will be to go with the nasogastric feed. If the post pyloric feed is recommended because of increased aspiration or because of poor feed tolerance, then you can go ahead with that also. Whereas if enteral feeding is not feasible for more than 72 hours in a high risk case, then you will have to consider parenteral nutrition. If it is a low risk scenario, then you can go waiting till period of 5 to 7 days also. So when you start the feeds, you start in the shock state, you started as trophic feeds around 10 to 20 ml per hour. If they are not in shock and you are starting it as part of a routine protocol, you can start it as 30 ml per hour and progressively increase it. Some ICUs increase the feed rate every 24 hourly, whereas the IACCM guidelines recommended to increase it every 4 to 6 hours. So by 72 hours, it would be ideal to get the target to the baseline, like satisfactory target. Like what energy requirement, the minimum is 25 kilocalories per kg per day. By around 72 hours, if you are able to get it, well and good, but it should be achieved within 7 days. Then important to assess for feed tolerance, you assess abdominal distension, whether there is nausea, vomiting, or aspiration of contents or diarrhea. So if any of those are there, then there is probably intolerance and that needs to be troubleshooted. And if persistent diarrhea is there because of malabsorption, then you will have to consider changing to semi-elemental formula feeding. So this was what I had mentioned about the nutritional assessment, road energy requirement, then symptoms indicating gut dysfunction. Reasons for intolerance that you need to keep in mind is oral hyperosmolar solution, especially when you give syrup potassium chloride, then antibiotics or sorbitol-based drugs. All these can cause osmotic diarrhea. So this is about enteral nutrition. So I would personally recommend those who are watching this to please take a screenshot. I had compiled all the disease states and made a table on the energy requirements, the proteins, and the preferred routes. And in the last, I have mentioned the key references also. So if you take it within 5 to 10 seconds, I'll then move on to the next topic.